So for the visual acuity, first introduce yourself and ask the patient to stand or sit at a designated testing distance about 20 feet from the Snellen chart. And then ask the patient to cover one eye using their palm, and then ask the patient to identify each letter in the chart on the lines of successively smaller optotypes until the patient correctly identifies only half of the optotypes on a line. Note the corresponding acuity measurement shown at the line of the chart, and then do the same procedure to the other eye. Retest the acuity with the patient using both eyes simultaneously. For patients with low vision, ask the patient how many fingers are shown. If the patient could not see the fingers, the examiner should move 1 foot closer to the patient. If the patient could still not identify the counting fingers, the examiner could wave her hand and ask the patient if she can identify the moving hand. Then, if the patient is still not able to see the moving hand, use the pen light and direct it on the patient's eye in all directions. For the external eye examination, observe the skin for any dermal or vascular changes. Note any lesions or any evidence of trauma. Note asymmetry of the facial bone, and also note the position of the upper and lower eyes. We can also assess for the effectiveness of the eyelid closure and the strength of the orbicularis muscle. We can also palpate the bony orbit for any lesion or deformity. And this concludes the external eye examination.
In performing the pupillary exam, observe the pupil size and shape at rest, looking for one pupil larger than the other. Observe the direct response or the constriction of the illuminated pupil. Observe the consensual response or the constriction of the opposite pupil. Repeat with the opposite pupil. Check for accommodation or the constriction of pupil when viewing a closed object. Direct pupillary response is a decreased room illumination would be helpful to visualize the pupils. Ask the patient to look straight ahead and use a pen light to examine the pupils of both eyes. The light can be shown directly into the eye by approaching it from side or below. The direct pupillary response to light is recorded in terms of briskness of the response. Observe the consensual reflex by noting the response to light of the non-illuminated pupil. The fourth part is the motility exam. Ask the patient to look straight ahead and then follow your finger without moving her head. Use the H pattern and let the patient track your finger. Note the symmetry of eye movements. Note if there are eye deviations. Note for any restrictions of eye movements. And note for any nystagmus that may be present.
Now, the fifth part is the confrontation test. You instruct the patient to look straight on the examiner, cover her left eye. The examiner retract her finger in one hand and ask the patient to state the number of fingers seen. Then, the examiner will repeat it in all 4 quadrants, testing at least twice per quadrant. You repeat it the same for the right eye. For this case, the patient does not have any visual abnormality in the visual field. If abnormality is detected, the visual field affected can tell where the lesion is most likely located.
Amster grid test is used to detect changes in the central or macular field of vision. Simply sit in a well-lit area and hold the grid at a comfortable reading distance, generally about 12 to 14 inches away. Wear your reading glasses if you normally use them. Cover one eye and focus on the black dot in the middle of the grid, but observe the pattern of vertical and horizontal lines in peripheral vision. Cover the other eye and repeat the test. Visual abnormality due to acute macular degeneration would cause some of the straight lines to appear wavy or blurry, or some areas would appear dark or blank.
The sixth part of the eye exam is the measurement of intraocular pressure. These could be assessed using different methods, examples of which are the Goldman applanation tonometry. According to the American Academy of Ophthalmologists, Goldman applanation tonometry is considered as the gold standard. It measures the amount of force required to flatten the corneal apex by a standard amount using a slit lamp attachment that uses the blue filter. Schutz indentation tonometry. On the other hand, the Schutz indentation tonometry is used to measure intraocular pressure by measuring the depth produced on the surface of the cornea by a load of a known weight. The indentation of corneal surface is indirectly proportional to the intraocular pressure. Palpation or digital tonometry. Lastly, we have the palpation or digital tonometry. The intraocular measure is estimated by the response of the eye to pressure applied by a finger. A firm to touch indicates a normal intraocular pressure, while a hard one indicates a high intraocular pressure.
Position the patient about 2 feet away and inform the patient on what you're about to do during the examination. Turn off the lights to dim and set the focusing lens of the ophthalmoscope to 0. Test the right eye first and check for the red reflex in a distance of around 2 feet. Approach the patient's eye. Steady the instruments against the patient's face by resting the ulnar border of the hand, holding the instrument against the patient's cheek. This is the fundus. In viewing the fundus, we first find the optic nerve by following the retinal blood vessels. From the optic disc, we follow the blood vessels outward to examine the 4 quadrants around the posterior pole and check for the foveal reflex. The last part of the eye exam is the slit lamp biomicroscopy. The parts of the slit lamp consist of 3 principal portions. First is the viewing arm that contains the eyepiece and objective lens. There is also the illumination arm that contains the light source and many controls. And lastly is the patient position frame that contains the headrest, chin rest, and handlebars. The slit lamp is indispensable for the detailed examination of virtually all tissues of the eye. It is routinely used for the examination of the anterior segment, which includes the anterior vitreous and the structures that are anterior to it. In addition to physical examination, it is also used in tonometry, linear measurements of tissues and lesions, and ophthalmic pathography. It can also be used in contact lens fitting.